Yes, so now it's 5 o'clock, and I would like to welcome you for the first webinar of the vascular section of the EANS. The vascular section thought for a long time if we should do the webinar or not, because we hope that the pandemic would not be so long, but then we realized that we should continue with education. And therefore, we also decided to make a series of webinars. As I said, this is a first webinar, and Dani Hengi, the chairman of the University in Düsseldorf in Germany, is giving a talk on the new aspects of aneurysm and aneurysm treatment. I'm quite happy that Dan is here. He's a well-known expert in this field, and I think he has to tell something which is of value for all of us. Daniel, the stage is yours.
Thank you very much, Veit. Thank you very much for the invitation. Good afternoon, everybody. I hope that you can see my screen. So it's a pleasure for me to talk today about the treatment indications for unruptured aneurysms and the aspect need to know. So I hope that I can give you some news on this what I do think very interesting topic. So I have some disclosures, but nothing is really relevant for this talk. And I thought to structure this presentation by having some data regarding the epidemiology, then of course regarding the risk of rupture, which is one of the most important things for us. Then the influence on the rupture risk, if there are some influences we can count on. Then the risk of treatment, the management, and a conclusion of this talk.
Daniel, just one thing I forgot during the introduction, that for the discussion afterwards, we need your input. And if you have questions, or then it would be nice to put it not in the chat box, but in the F&A box, so that I can see the question, and then we can go through it at the end of the talk. Sorry, Daniel, for interrupting.
No problem. Thank you, Veit. So regarding the epidemiology of unruptured intracranial aneurysms, we will have a population of 7.5, and we do think that we have a prevalence between 2 to 3% of humans with unruptured intracranial aneurysms. So this means that this is well in line with, for example, the prevalence of hepatitis C. So that we have per year around 700,000 patients suffering from aneurysmal subarachnoid hemorrhage. We do know today that aneurysms are non-congenital. We do know that there is some degenerative aspect that, well, this is an idiopathic disease, that there might be some genetic influence, and that there might be some environmental influences, for example, some geographical differences regarding studies we do have from different parts of our world. So this is important to demonstrate if we talk about epidemiology. These are the imaging data, MR scans, obtained in 2007 and obtained in 2017. So there is an time interval of 10 years in different countries. So for example, you can see here on the left side, Germany and France. And you can see that in each of these countries, and so it is the OECD, the median value, but you can see that in each of these countries, the number of MR scans went up, well, to a, I have to say, to a dramatic number. So it's a significant increase of MR scans of the brain, which is important regarding the treatment of unruptured intracranial aneurysms. And if we go to the worldwide statistics regarding MR imaging per 1,000 population in 2019, so 2 years ago, we have Germany on the top with close to 150 MR imagings per 1,000 people of population. And on the other hand, well, we have here Chile with 31 humans, but here you can see Austria, like the United States, which is also important, well, in between, well, the Netherlands. So I think interesting data we should know today if we talk about then, well, the treatment or the treatment recommendations of patients with unruptured intracranial aneurysms. So this is a publication from Lancet Neurology in 2011 demonstrating that there is an increase of diagnosed unruptured intracranial aneurysms. You can see here, starting from 2005, and this was an estimation to 2017, that there is an increase of unruptured intracranial aneurysms overall, that there is an increase of unruptured intracranial aneurysms in the female population as well as in the male population, which means that the number of well, diagnostics went up, and as well the number of unruptured intracranial aneurysms went as well up, which is important. So we have the dilemma that we have a, well, population of 7.5 billion humans, and we have about 700,000 aneurysms a year, aneurysmal subarachnoid hemorrhages a year, sorry. And from this number and from this statistics, we know that the minority of cerebral aneurysms do rupture. And our dilemma is, well, the identification. And I think that in vascular centers, this is our daily business to analyze patients regarding the recommendation of treatment of patients with unruptured intracranial aneurysms. Regarding the rupture risk, we have the biggest data from the so-called PHASES study, and this was published in 2014, where we had more than 8,000 patients with more than 10,000 unruptured aneurysms. And this study was able to identify 6 independent risk factors. So regarding the rupture risk, it is, I think, important to know that from this analysis, we had data from different geographical regions, so from United States as well as so North America, Canada. Then we had data from Europe, we had data from Finland. Important to say we had data from Asia, especially from Japan and the Netherlands. We had a recruitment period, yeah, basically from the 90s to 2004, 2006. We had, of course, the inclusion criteria, which was a saccular aneurysm, not a fusiform one, not any other sort of aneurysm. And then, of course, we had, well, the high number of patients with these unruptured aneurysms. And from this pooled analysis or meta-analysis, we identified some basic rupture risk factors, which are mentioned on the right side. So if you can see here, it was included, of course, the age of the patient, which is important. It was included hypertension, ever smoking, which means smoking, not, for example, nicotine. Then the previous SAH from an aneurysm. Then, of course, the size of the aneurysm location, and the geographical region. And regarding this analysis, it was found that the population is of importance, which means that there must be a difference between patients with unruptured aneurysms, intracranial aneurysms, for example, in North America, in comparison to the Japanese or to the Finnish population. Then the criteria of hypertension, that there must be an influence, that this must increase the rupture risk. Then the age below 70 years old and the age above 70 years old. And then very dramatically, very significantly, well, the size of the aneurysm, then the earlier SAH from any other aneurysm, and then the site of the aneurysm, which gives you the so-called phases aneurysm risk score, which I do think is very important to know if we do talk to patients with unruptured intracranial aneurysms. From this study, from the phases study, then we have seen that the rupture risk increases significantly with the scoring rate. So which means that below 2, that there was a very, very low rupture risk. And then, we had this curve up to over 12, where the risk of rupture, so the 5 years risk of aneurysm rupture was close to 20%, which is a high risk, I do think. And I think that the phases score is one of the first really scores you should know regarding the title of this presentation. Need to know, if you talk to patients, if you estimate the risk of rupture. The next thing was the analysis of the aneurysm growth, because aneurysm growth was not included in the phases score or in the phases analysis. And this was done later by this publication in 2017 in Neurology, where also patients were included with unruptured intracranial aneurysms. And again, we had the parameters like earlier subarachnoid hemorrhage, the location of the aneurysm, age was here, the cutoff was 60 years old. Then again, the population, the size of the aneurysm, and then very important to mention the shape of the aneurysm, which was completely different if you have a regular shape of the aneurysm or an irregular shape. So one of the new aspects, one of the additional aspects in contrast or additional to the phases score. In this so-called ELAPSE score then, it was shown that the predicted 3-year and 5-year risk of aneurysm growth was related to the mentioned parameters. So again, you have the ELAPSE score of less than 5. If we go back here, you can just count the points for these different parameters. And then if you count the points, and if you are less than 5, you have a very, very less risk of aneurysm growth. And if you count more than 25, you have a very high risk for aneurysm growth. And that we do know that aneurysm growth is one of the most significant parameters for then aneurysm rupture. So I do think, despite phases, that the ELAPSE score is also very important to know for the treatment of our patients. As I mentioned, in phases, it was not, or the shape of the aneurysm was not included, and this was later done again by a meta-analysis by Gabriel Rinkel, that the shape is of importance. So here in this later analysis, again obtained from data, for example, from the phases score, so from some studies included in the phases score, it was demonstrated that, as I mentioned, the shape of aneurysm is very important. So there is if you have a regular shape, it means that you don't get that you get 0 points, and if you have an irregular shape, that you get 4 points, which is a significant increase. So for example, an irregular shape means to have an aneurysm with a bleb like here, or with a daughter sac like here, which is then an irregular configuration, and which leads to a higher predicted 3- and 4-year risk of growth and rupture of the aneurysm. So shape of the aneurysm is as well of importance. And then, and these are, these data are obtained from studies over the last 5 years. It was shown, from different scientific researchers that the contrast enhancement is as well of importance. So you can see here on the left side the MR scan of a basilar tip aneurysm, and this is without contrast. And you can see here the same aneurysm after contrast enhancement, and you can see the enhancement in the wall of the aneurysm, or around the wall of the aneurysm, which means that there is a higher risk of rupture for aneurysms who do have a contrast enhancement by doing an MR scan. So again, one important factor to know if you estimate the rupture risk of your individual patient. On the other hand, it was shown in this study, and this was published 2 years ago by Mensing et al., that there is a difference if you talk to patients with familial versus sporadic unruptured intracranial aneurysms. Here in this study, it was very nicely shown that, and it was obtained from patients' familial aneurysms 62 versus sporadic aneurysms 412. It was shown that the patients suffering from a history of familial unruptured intracranial aneurysms have a much higher rupture risk than the patients with sporadic aneurysms. So if you talk to patients, you have to ask, especially if you estimate the rupture risk, about their familial situation. So it's not only the situation of having that in familial aneurysms that they do have more aneurysms, it's also the situation that the rupture risk is higher, which was demonstrated in this publication, I do think, very clearly and very significant for the first time with this publication. So after the epidemiology and after all the risk factors for rupture, it is probably important as well to know a little bit about the pathophysiology of aneurysms. Today we know that there that we have different scenarios for patients suffering from unruptured intracranial aneurysms. We know that we have in these patients that we have a situation of growth and or rupture of the aneurysm, and of course that there might be an influence of rupturing of an aneurysm regarding the hemodynamics. And this is the typical curve. What we do think that you have a stable situation, and then you have a phase of growth phase, and then you have a stable situation, and then you have the situation of being stable or of growth and rupture, which seems to be the typical timing situation for patients with unruptured intracranial aneurysms. From my former group, it was demonstrated that there is an influence, or that there might be an influence on the rupture risk of patients with unruptured intracranial aneurysms. So this is from the other side. So this is a study investigating the rate of aneurysm subarachnoid hemorrhage, showing that there is a decrease of patients suffering from aneurysmal subarachnoid hemorrhage worldwide. And well, they measured in this, or they analyzed in this publication 2 factors. So one factor was the mean systolic blood pressure level, and the other one was the smoking prevalence, demonstrating that there is a correlation between well, the treatment of mean systolic blood pressure and of stopping of smoking, that there is a correlation between these 2 factors and the risk of having an aneurysmal subarachnoid hemorrhage, which then might put the question that probably if we do well focus on these 2 situations, so controlling the blood pressure and stop smoking, that we can reduce the rate of patients suffering from aneurysmal subarachnoid hemorrhage. Well, this leads then to the first study from the same group investigating like the medical management of patients with unruptured intracranial aneurysms. It's a binational study done in Germany and in the Netherlands. And there is a 2-arm study. So the first group, that the treatment group, is intensive blood pressure treatment and the treatment of aspirin. And the control arm is standard blood pressure treatment and no aspirin. And the study is an ongoing study. Estimation is about having more than 700 patients, and we will wait for the results hopefully in the next years. So now I want to well, change from epidemiology, rupture risk, and from the influence on the rupture risk to the treatment risk, which is also, if you talk about, if you want to give a recommendation for your patient, which is also of utmost important. And regarding the treatment risk, we don't have that much really good prospective randomized data. But we have 2 meta-analyses, and this is the first meta-analysis from Canada, well, including well, a lot of patients, close to 10,000 patients, well, receiving surgical treatment and receiving endovascular treatment. And well, it was analyzed the quality of the study, the origin of the study, then of course the year of the treatment, which is especially important for the endovascular treatment, then the age of the patient, location, and the size of the aneurysm. And it was shown that especially parameters like location of the aneurysm and of course the size of the aneurysm is well, close related to the outcome of these patients. And this is the other meta-analysis obtaining or analyzing less patient data, about 5,000 patients, again with the same parameters, but basically demonstrating the same statistical result, that we have a treatment risk, that we have an overall morbidity rate of 6.7% regarding the treatment of patients with unruptured intracranial aneurysms, and that we have a mortality rate of 1.7%. And if you go into detail of these studies, that there probably might be one rule, I call it my rule, but it's from these data, that you can estimate that you have per 1 millimeter diameter of the aneurysm, that you have a 1% risk rate of morbidity in patients you do treat with an unruptured intracranial aneurysm. I think, well, a good information you can give to your patient if you talk to him. If we talk about the treatment risk and the modality comparison, we don't have, or we even have less data than the overall treatment risk. And there was one first, I would say, pilot study from Tim Darceau in Canada, showing these results between it was the surgical treatment versus the endovascular treatment, and results obtained so at discharge after 6 weeks and after 1 year. But this study had only a few number of patients, and so it's very difficult to analyze. It is important that after this pilot study, there is an ongoing study as well in Canada. It's a so-called CURES study, analyzing in a prospective randomized matter or design surgical clipping or any other endovascular treatment. So this study includes simple balloon-assisted or stent-assisted coiling, and the endpoints are first of all the clinical outcome of patients and the radiological outcome of patients. But this is an ongoing study. It's, to my knowledge, a study in a national study in Canada, and I do think that the inclusion is not that easy. So we have to wait for the results of this CURE study in the future. So now coming more to our daily business, I just want to demonstrate two cases. And on the left side, you can see well, this aneurysm. It's a as you can probably see, it's an ACOM aneurysm of this size, I would say. And on the other hand, it's well, this aneurysm. It's a carotid artery and aneurysm located here. And of course, if you want to talk to this patient, you need some more information. So the patient with the ACOM aneurysm, it is a 47-year female, received an MR due to persistent headaches. It was diagnosed with an ACOM aneurysm, as I mentioned and as I have shown. Risk factor is arterial hypertension, no comorbid disease, largest diameter is 7.6 millimeter, and it's an irregular shape. And on the other hand, you have a 25-year-old female received an MR as well due to persistent headaches. It's an incidental ICA aneurysm. Risk factors are none, related symptoms are none. The largest diameter, it's probably from here to here, is 3 millimeter. So it's in the very wide neck. And so how would you talk to these patients? What would you personally recommend at your institution? I've shown and told some, of course, factors regarding the rupture risk, regarding the influence on rupture risk, and regarding the treatment risk. So what would you recommend for these two very individual and very different patients? And for this, you always have to balance the risk of rupture. And the risk of rupture, again, this includes the patient age, the aneurysm size, the location, and the morphology. And then very important, the growth, the de novo formation on serial imaging, which is one, I do think, of the most important parameters. Then, as I mentioned, risk factors like previous SAH, the familial situation, smoking and hypertension, as well as the geographic location. And on the other hand, you have the risk of treatment, which means the risk of aneurysm treatment. And this is related to, as I mentioned as well, to the size of the aneurysm, to the location of the aneurysm, and to the modality of treatment, and the risk of patient treatment, which means age of the patient, comorbid diseases, etc. So if you go back to the FACES score, then you have, for the first patient with this ACOM aneurysm, you have, if you count again the FACES score, you have a FACES score of 8, which means that you have a rupture risk here in the middle. So which means that you have a risk of rupture per 5 years risk of rupture above 2 or 3.2%. If you go to the other patient, you have to face a score of less than 2, which means that you have a rupture, a 5-year rupture risk of the aneurysm of 0.4%, so completely different situation. Then to include the situation of the treatment, because we have to balance, as I mentioned, the risk of rupture and the risk of treatment. There was published a Delphi-based expert consensus. It's called the UITS score, trying to integrate on a Delphi analysis, so which means an expert opinion, the balance between risk of rupture and the balance between risk of rupture and of risk of the treatment. And if you go to this, to this score, which was also validated with different experts, then you have for this patient, you have the scenario. If you count again age, risk factors, etc., then the aneurysm situation and then the treatment situation, that you have 13 points versus 7 points, 13 points supporting the repair of the aneurysm. And I'm not talking about the surgical or the endovascular repair, but the repairing of the aneurysm, 13 points for supporting versus 7 for the conservative management, so that in this situation that you would recommend more the treatment of the aneurysm. And on the other hand, for the other patient, you have a completely different situation, that you have 4 points supporting UIA repair versus 8 points supporting UIA repair, so that you would recommend for this young lady more the conservative treatment, probably. This, I think, is very important to know, and I think based on these different calculations, you can really talk to patients based on a good data situation regarding their treatment. I would like to a little bit more come to the end of this webinar, that of course we have a pandemic situation, that I want to talk about unruptured intracranial aneurysms and COVID-19, and that we don't have that much data about the influence of COVID-19 and unruptured intracranial data, but that we have one publication demonstrating that during the COVID-19 pandemic, and this is here, it's the analysis started in January 2019, and then of course we know that in March 2019, and then moreover that we have in total that we have, and this is only focused on endovascular treatment, that we have a less treatment, around 45% less treatment of unruptured intracranial aneurysms, and that we have during COVID-19 that we had 30% less angiographies, cerebral angiographies done in patients with unruptured intracranial aneurysms, so that there is, of course, an influence of COVID-19, of the pandemic of COVID-19, and the diagnosis and the treatment of patients with unruptured intracranial aneurysms. So in conclusion, and well, this is a conclusion like a need to know conclusion, I do think that it is, well, very important to know exactly the phases score, and that we of course do have to know additionally the ELAP score, which was investigating well, the growth of the aneurysm in serial imaging. I do have to know the UITS score, because well, this score is well, a combination of the treatment or the rupture risk and the treatment risks. And well, I do think that, of course, in the future, that we need some more information regarding genetics. For the imaging, I'm quite sure that we will have in the future more data, because we do know today that the morphology, the shape of the aneurysm, is very important to analyze regarding the risk of rupture. We do have some data, some studies that inflammatory imaging is important as well to detect the aneurysm, which is at risk of a rupture. And as well, we need tissue imaging to answer this question. I'm looking forward to the conservative management of patients with unruptured intracranial aneurysms. So the influence of drugs, as I mentioned, the first study or investigating the blood pressure treatment with aspirin versus without aspirin, which is of course of important. And regarding the treatment morbidity, I think it's very difficult to answer so far. I do think that we need much bigger data, so that the big data analysis regarding treatment morbidity with all the influential factors is of importance. At the end, I would like, of course, to mention the Congress of the EANS in Hamburg in October. This is our hospital, our surgical hospital, and this is the vascular group working in Düsseldorf, so clinically, and the research group. I would like to thank for the attention, and of course I'm very happy to answer some questions. Thank you very much.
Yes, thank you, Daniel, for this very nice and informative overview on the topic of unruptured aneurysms. At the end, 5 questions popped up from the audience. And I also have some questions, but I would be happy if the audience would become more active in the upcoming minutes, because we have time left for a fruitful discussion. So I would propose that I go through my list of questions. So there was one question from Carlos. He asked, patients included in the PHASES study were those not presenting with high-risk features requiring treatment, therefore underestimating the real rupture risk. Could this concept be discussed? What we all have seen, a small ruptured aneurysm in clinical practice.
Can you repeat the question? I didn't get the point.
Okay, patients included in PHASES study were those not presenting with high-risk features requiring treatment, therefore underestimating the real rupture risk.
Thank you for Carlos for this comment. I think this was discussed within or after the PHASES publication. To be honest, I think that this is partly true, because of course in PHASES it was an inclusion of patients with strong saccular aneurysms and not so any other ones. So regarding PHASES, I think this is an estimation of the rupture risk, but in combination with the ELAPSE score, in combination with the radiological features, which means shape of the aneurysm and probably like contrast enhancement, we do get a more precise real rupture risk rate of an individual patient with an unruptured intracranial aneurysm. So this comment is absolutely right.
Okay, possibly I also asked myself when I have heard your talk and seeing the growing curve and the phases score. So where do you think the cutoff would be if you have a slowly increasing curve?
You mean a slowly increasing course of the size?
Of the rupture risk. So if you're using the phases score, you have nicely shown that the risk is stepwise increasing.
Yeah, yeah.
And so I asked myself, not taking the UITS score, but only looking at the phases score, do you think there could be some cutoff point when we could say, at this point, it's still safe, and if we are going on in the curve, then it's too risky?
Well, well, a good question, but I think it's a cutoff point is very difficult, and that's what I mean. UITS tried to find that you really have, you know, the balance of the aneurysmal factors, of the individual, the patient's factors, and the rupture risk factors, and then the risk of treatment. And if you balance this with the scoring system I mentioned for both patients, I mean, then you have, for example, 12 versus 4, and then you have to, you know, to decide. But there is no, I cannot give any cutoff point. That it's a multifactorial situation, and you always have to respect this multifactorial influence. So a hard or a true cutoff or one number is not enough, I do think.
Let's say it in a more simple way. You're using the UITS score or the phases score or both for talking with a patient?
Well, I mean, we really try to use the combination of phases, of ELAPS, and also the radiological parameters, and then in respect with the treatment risk, and then we decide, and then we count, and then we analyze the pros and the cons for treatment, and then we decide, and then we discuss together.
Okay. So I have another question from David. He asks, can any of these data applied to recanalized coiled aneurysms?
This is very difficult to answer because, first of all, I do need to know if these aneurysms are previously ruptured or non-ruptured. And I would say, I mean, these data I have shown cannot answer the situation, but if you have a recanalized, previously coiled ruptured aneurysm, I do think that you have a higher risk that this aneurysm will rupture again, versus if you have an aneurysm which was treated endovascularly in a non-ruptured situation, that the risk is less.
Okay. Do you think that in the upcoming year there would be some attempts to develop a scoring system for, let's say, the not completely coiled or revascularized unruptured aneurysms treating endovascularly?
It's well, I hope that there will be a scoring system. I know that, or we know that revascularization is a problem. So we should analyze revascular or in non-complete endovascular situation. There are some grading systems for that, and then I hope that there will be also a scoring system. And I mean, this question goes into the future, on questions of our future. And of course, we will see more patients after endovascular treatment with a recanalization or with a remnant of the aneurysm. So we need to get some more data then probably to develop a score for this patient cohort.
Okay, there's a question from my department, which is stunning me. So the question is, considering the massive evolution of endovascular treatment modalities, do you think the general assumption of ISAT that endovascular aneurysm treatment is better than traditional coiling still is existent or not?
Well, this is now very difficult to answer because my topic was today unruptured intracranial aneurysms, and ISAT is not dealing with unruptured intracranial aneurysms. But to answer, well, in a very general way, I do think that we have, for both modalities that there is and that there will be a future, and I think that at the end that this very friendly competition will lead to a better treatment of patients with unruptured intracranial aneurysms, but as well with ruptured intracranial aneurysms.
Probably I might also comment, because it was not the general assumption of ISAT that endovascular treatment is better. It was because it was the equipoise was between, or the uncertainty which is better in different locations, and that was I think the general assumption of ISAT.
Yeah.
Okay, there was a anonymous participant from Italy, and he said it was very informative, your webinar. And he said that in the case of the young women with the ophthalmic aneurysm, the UERTS score said that no treatment, but he asked, and this is what we always should consider about the, let's say, the psychological factor of having an aneurysm. How do you deal with this?
I mean, very important question. Thank you very much. The psychological factor is not integrated if in any of these scoring systems so far, and that's what I tried to mention in my talk. That of course we have the more obvious data, and then we have this situation, the psychological situation, and this if this is for the patient a very severe situation, and of course then you have to take account the psychological factor into your treatment recommendation. But this is also a situation you talk to the patient. You can of course talk to the patient in a very honest way, to say to this young lady that the rupture risk of her aneurysm is so less that there must be not a high psychological influence. But of course you can talk completely with the opposite aim, but psychological situations, or the psychological situation of an individual patient in this situation, is always important.
Okay. There's a question from Radek. I think he's still in Norway. So he asks, what risk of complication % related to surgery do you communicate in patients when counseling regarding prophylactic surgery?
Yeah, it's a little bit that rule I mentioned, that I do think, if you go to this 2-meter analysis, it's about, if you go into detail, it's really about that you have per millimeter of the aneurysm, that you have a 1% per millimeter of the morbidity rate, and that's what I try to use. But it's very difficult in the individual situation, but these data are obtained from 2-meter analysis, so there must be some truth in it.
Okay, so I have a question about the definition of morbidity. That's always this discussion. So if you're performing endovascular treatment, so you have the, let's say, neurological morbidity, but if you're performing clipping, you have the risk of neurologic deficits plus the surgical risk. So it's still then well balanced between the two groups?
Yeah, you have I mean, in these two meta-analyses, they focused on the neurological situation. So any other like surgical risk, like infection, wound healing, was excluded, but as well as for the endovascular treatment, like a hematoma, things like that. It was focused on the neurological situation of the patient after the treatment.
There's a question from Heidelberg. What factors do you consider in terms of balancing risk of rupturing and risk of treatment when choosing between microsurgical clip ligation and endovascular flow diversion?
All the parameters I mentioned. So these are, the patient factors like age, like comorbidities. Then of course the aneurysm factors like the size of the aneurysm, the base of the aneurysm, the location of the aneurysm. These are well, the factors I integrate into. It's not my decision, into our decision. We always talk together with our colleagues from neurology, then trying to obtain a common sense decision on the treatment of an individual patient.
There's a question from Sylvia. It's again related to the ICIT trial, and she's asking if possibly we need a new, let's say, ICIT trial or another trial, because we have a lot of new devices for endovascular treatment, all the web devices and so on and so on. Do you think that we still can transfer the data from the ICIT into the real world of today, or if we should consider together with a neuroradiologist to go on for another study?
Yeah, I mean, good question. I think data are very old, especially regarding the evolution of the endovascular treatment situation. So it would be, I mean, there was an attempt, it was called, or there are some attempts. One was called the IDA2 study. But of course, it would be great to have another prospective randomized international trial comparing both situations. But ISAT was for the ruptured ones, but also as we do have, for example, with the Canadian study, with the CURE study for the unruptured ones.
Now I have three questions which are, let's say, belonging together. One is from Shadi, one is from Klaus, and one is from an anonymous panelist. So they're asking about the role of follow-up. So if we are treating an aneurysm conservatively, when do you advise, which control imaging studies do you advise, and when? And which modality, MRI, DSA? Very, very good question. Very difficult to answer. There are different studies investigating this situation. The one is on the one hand that it would be, I mean, for the majority of patients, it would be good to have a serial imaging. And I would always prefer MR imaging to control patients with unruptured intracranial aneurysms. So no angiographies and no CT angiographies. I think MR scanning is good and is enough. But on the other hand, if you do this every year, and then again, we will talk, or we can talk about the psychological situation, and that there are, I mean, studies demonstrating that in patients, you do a serial imaging every year, that you have a higher psychological negative impact, so that you probably should stop or should do this imaging in a more extensive way. So every third year. Okay. So that's because that's a very clear question. So what time interval would you recommend for follow-up of stable non-growing aneurysms? So you would prolong the follow-up period, right?
Yeah, but it's the question is clear, but the answer is also again very individual, because if this is a very small aneurysm, like the case, the young lady with the ophthalmic aneurysm, I would say 3 years after one, I would control after 1 year, and then I would say every 3 years is enough. But if there is a patient with again carotid artery aneurysm, same location, but size of 4.8 or 8 millimeters, then I would recommend a serial imaging every year. And again, take in account risk factors like hypertension, smoking, things like that.
Okay, so there's one very, inflammatory images. What sequences do you use?
Well, we do not here in our hospital. We at the moment we do not use any inflammatory MR imaging, but we do the black blood imaging to also to detect an unstable situation for unruptured intracranial aneurysms. But if you do, I mean, for the inflammatory imaging, there are different suggestions to use. I mean, there was one of the first study was from, and he was like a pioneer in thinking about this situation, was from David Hassan in the US, using MR imaging with a certain inflammatory contrast dye for these patients.
Okay, so there's a very the case. It's a question from a case. So it's a 55-year-old male Caucasian with an incidental basilar tip aneurysm, 5.5 millimeter, with no angiographic evidence of complication complicating the perforator. So the perforators are not involved. Patient is either worried nor very relaxed about the news. Would you consider treatment, and if yes, with which method?
So then I would try to ask about the other risk factors I mentioned, about hypertension, smoking, familial history. It's the detection for the first time. It's 5.5 millimeters. It's the basilar tip, so it's the posterior location. Then I would rather, I would more go for treatment than for conservative management. And the treatment modality would be, of course, endovascular treatment.
There's a question from Sasha, and he also had a great talk. And the rule of thumb, rupture risk 1% per year. Should we not treat a 25-year-old patient? Do you think that the rule of thumb does exist? Probably not.
Well, it's not a rule which exists, but it's a little bit my.
No, I think it's not that your rule about the millimeter and the risk of treatment, but I thought it's an overall rule. So taking all the group of aneurysms together, that if you're looking at the whole bunch of aneurysms, so 1%, if you look at the FACES score, 1% per year rupture risk. And if you're looking, into the future of a 25-year-old patient, that he is accumulating a risk. So I think the main question is, should we consider the patient age concerning the life expectancy?
Yes, of course, but and this is a difficult situation in a 25-year-old lady. But well, the rupture, I mean, it's a little bit the dilemma, and the rupture risk is like the rupture risk is, and we have a high prevalence of unruptured intracranial aneurysms. So let's say 2.5 of 100 people do have an unruptured intracranial aneurysm, but we have a low rupture rate, and it is completely different than we thought 20 years ago, when we thought that an aneurysm, the only task for an aneurysm is to rupture. That's completely wrong. A minority of intracranial aneurysms do rupture. So it's it's here more that we, of course, we have a higher detection rate, but still we have a very low rupture risk for that 25-year-old lady.
Okay. There's a question from Mohammed. Do you usually recommend patients with aneurysms to get their family members screened for aneurysms? And how do you go about this subject in your practice?
So if we talk to patients after in a ruptured situation, and if they have first-grade relatives, of course we do recommend a diagnosis for the families of first-grade family members. To be honest, it was not the same for patients with unruptured intracranial aneurysms. But after this latest study, demonstrating the significantly higher risk for patients in a familial situation with unruptured intracranial aneurysms. Well, in this situation, of course, I would recommend in the future also doing an MR for first-grade relatives.
Question from David: with regards to serial imaging, do we truly know if all aneurysms enlarge, or is there an aneurysm cohort that stays the same size over time?
There are a lot of studies demonstrating that aneurysms can be stable over a long time.
Okay. So, and the final question is from Marco. I don't know if it's a good question for a neurosurgeon. I would like to ask, how do you perform to follow up patients after endovascular embolization? By which diagnostic modality and at what periods of time after procedure?
I like the question also for a neurosurgeon. It's thank you, Marco. Well, we do recommend a serial MR imaging every year.
Okay, so now we are at 6. So I would say that there's still 2 questions coming in. So if there's still some questions left, just type them in now. So there's one from Barbara. Do you consider the psychological effect causing stress? Do you consider causing stress? Yes, I think we are already answered this question, that you consider the psychological stress.
Yes, yeah.
So Piotr asked, how important is a psychological influence again? Especially if the patient is insisting on treatment. So how you're counseling patients in which you think, I think there's no need to treat, but if the patient is pushing you a bit.
Well, then I try to be, it's an important factor, but then I try really to be very transparent with the risk situation of this individual patient. But of course, then there's a psychological factor. But again, I had some cases with very, very small aneurysms. Patients wanted treatment, but I denied, because the risk of treatment is was in this situation much higher than the risk of rupture, so that I denied then the further treatment of these patients.
I think in this situation also let's say the surgical risk is getting more in foreground, even if surgical complications are rare. So they must be considered, and to be honest, in counseling the patient, they must be added to the neurological risks.
But it's not only but it's not only the surgery; it's also the endovascular. So really, we try to discuss every patient together, and also my colleague from the endovascular department will decided not to treat, which I think is a very, for us, a very honest situation.
So this seems to be the final question. Do you do DSA to analyze the morphology of all cases with unruptured aneurysms during their follow-up when it's not treated? And what modality of imaging do you use for following up these untreated patients? I think the second thing we already answered, but the first part of the question is very interesting. Do you look through the DSA together with a neurologist and go into detail on the morphology, or is, as it's often in the, let's say, daily routine, or the aneurysm is not so big and let's go on and look for the next spine case? So how is it done in Düsseldorf?
The answer is always in between. I mean, we try to do, and we should do, of course, because we know that shape of the aneurysm, configuration of the aneurysm wall is very important. But as you mentioned, sometimes daily business is demanding. Since we do not have a real, at the moment, focused study on shape and configuration of the aneurysm, so we do not do an exact angiographical analysis in every of our patients.
Okay, Daniel, this was the last question. I think it was a very nice and informative discussion, and I hope all of us learned something. I learned a lot, I must say, and it's always also good to see again the scores, because sometimes they're not so in mind if you're in the situation of counseling the patient. I thank all the participants. So we have had about 170 to over 200. I think it's quite good sign that vascular neurosurgery is still very interesting for the neurosurgeons in Europe and all over the world. And thanks again for taking your time for taking part at this webinar. Thank you. Bye-bye.
Thank you. Bye-bye.